Hello everyone. I am myself Dr. Rajesh Guba. I am the general medicine educator. In this session, I will be discussing a very important topic in the cardiology, that is the constrictive pericarditis. Right? That is constrictive pericarditis. So, what exactly is the definition of the constrictive pericarditis? Constrictive pericarditis, it is a condition in which the pericardium becomes thickened, scarred and often calcified. Right, so the pericardium it is often being thickened, scarred and it is often calcified. That is what will be the abnormality that will develop within the pericardium. Okay, and because of the thickening of the pericardium, right, because of the thickening of the pericardium, what will happen? There will be diastolic dysfunction. Right, there will be diastolic dysfunction. And because of this diastolic dysfunction, there is increase in the pericardial pressure. Right, there is increase in pericardial pressure. Okay, so there will be increase in the pericardial pressure because of the thickening and calcification of the pericardium. There will be increase in the pericardial pressure, and due to which there will be diastolic dysfunction. And this condition, it is more or less similar to that of cardiac tamponade, but there are certain differences. What are those differences? I'll tell you. So the differential diagnosis, what you need to consider when you are considering a patient with constrictive pericarditis is the cardiac tamponade, or in fact I will tell pericardial effusion. Okay, because even in pericardial effusion also there is increase in the pericardial pressure, due to which there will be diastolic dysfunction. Now let me just show you how the pericardium appears or how the pericardium looks. See, this will be the normal pericardium. Whereas here you can observe the thickened or scarred or the calcified pericardium. Right, now you need to know what are the most common causes of the constrictive pericarditis. Most common causes of constrictive pericarditis will be tuberculosis pericarditis, and this constrictive pericarditis, this can be also a sequel of pyopericardium. Right, this can be also a sequel of the pyopericardium. Now, what are the other causes of constrictive pericarditis? So, if you see the other causes of constrictive pericarditis, trauma is one of the very important cause. Then mediastinal irradiation is another important cause of constrictive pericarditis. Then purulent infection is a very important cause for constrictive pericarditis. Then we also have fungal infection, and this particular fungal infection include histoplasmosis. Even this can cause the constrictive pericarditis. And we also have some neoplastic diseases. And these neoplastic diseases include carcinoma of the breast, carcinoma of the lung, and then lymphoma. Right? And then lymphoma. So these are the neoplastic diseases which will cause the constrictive pericarditis. Then followed by that, rheumatoid arthritis, which will cause constrictive pericarditis. Then followed by that, SLE will cause constrictive pericarditis, and then chronic renal failure. So these are all the causes for constrictive pericarditis. Next, followed by the discussion of the etiologies causing constrictive pericarditis, let me tell you, this constrictive pericarditis, it rarely occurs following recurrent pericarditis, right? It rarely follows recurrent pericarditis. So this recurrent pericarditis will progress to the development of the constrictive pericarditis. And the risk of constrictive pericarditis due to viral or idiopathic pericarditis, it is less than 1%. Okay. So the risk of constrictive pericarditis following viral or idiopathic pericarditis, it is less than 1%. Okay. And this constrictive pericarditis, its occurrence increases following immune mediated or neoplastic pericarditis, and it is highest in occurrence following bacterial pericarditis. Right? Following bacterial pericarditis, the chance of this constrictive pericarditis is highest. And what are the other causes? The other causes, as already I have discussed, that is the post-cardiac surgery, radiation therapy, and then the connective tissue disorders. And a small number, right, a small number of cases, they are drug-induced or secondary to trauma, asbestosis, sarcoidosis, or uremia. Right? So that is about the etiologies which will cause the constrictive pericarditis. And we have one more terminology called effusive constrictive pericarditis. Now what is this effusive constrictive pericarditis? See, at times what will happen is both cardiac tamponade and constrictive pericarditis may coexist. Right? So what is effusive constrictive pericarditis? Sometimes both sometimes both cardiac tamponade and constrictive pericarditis both of them, they can coexist. And this particular condition is referred to as effusive constrictive pericarditis. Now, the only definitive way to diagnose this condition is to reveal the underlying constrictive physiology once the pericardial fluid is drained. So, how can you make out that the individual has developed constrictive pericarditis in the presence of the cardiac tamponade? So, after draining the fluid, right, after draining the fluid, if still, right, if there is presence of constrictive physiology, right, if there is presence of constrictive physiology, then we consider it to be having, the individual is having both effusive, constrictive pericarditis. Now, you see another question. Hemorrhagic pericarditis occurs in all of the following conditions except transmural myocardial infarction, dissecting aneurysm of the aorta, metastatic disease of the pericardium, constrictive pericarditis. So let me tell you, hemorrhagic pericarditis, you will see that in transmural myocardial infarction. You will see that in dissecting aneurysm of the aorta, and you will see that in case of the metastatic disease of the pericardium. And the condition where you will not have the hemorrhagic pericarditis is in case of the constrictive pericarditis. Now, what are all the various causes of the hemorrhagic pericarditis? So, if you see the causes of the hemorrhagic pericarditis, it includes number 1, tuberculosis. Next, malignant involvement of the pericardial sac. Right, malignant involvement of the pericardial sac. Then bleeding diathesis, cardiac surgery, post myocardial infarction, dissecting aneurysm of aorta, then uremic pericarditis. Okay, so these are the causes of the hemorrhagic pericarditis, right? Now, after having discussed about the various etiologies which will cause constrictive pericarditis and hemorrhagic pericarditis and effusive pericarditis, let me discuss the pathogenesis of the constrictive pericarditis. See, in patients with constrictive pericarditis, the pericardial pressure is increased, or the pericardium, it is calcified and thickened. Right, it is calcified and thickened. Now, because the pericardium is being calcified and as well as thickened, there will be development of diastolic dysfunction. Now, because of the development of diastolic dysfunction, there will be increase in the filling pressures. Right, there will be increase in the filling pressures of the atria, because your ventricle is unable to relax. So when ventricle is unable to relax, the atria, it cannot send the blood into the ventricle. So thereby what will happen to your atrial pressures? Atrial pressures are elevated, atrial pressures are increased. So there will be increased filling pressures of the atria, right? Now, that is the reason why whenever the AV valves open, that is the mitral valve and tricuspid valve opens, let me tell you what will happen is that increased pressure within the atria will gush the blood into the ventricle. So there will be a deep, rapid Y descent. Okay, so there will be accentuation of Y wave in JVP. Now, you need to know what is Y wave in JVP. Right, in the section of JVP, I have discussed about the individual waves in detail, but let me tell you, the Y wave in JVP, it tells you about the atrial emptying. Right, it tells you about atrial emptying. That is what is the Y wave in the JVP. Right, now, why the Y wave is accentuated? Because the atrial pressures are very high. Why the atrial pressures are very high? Because the ventricle is unable to relax. Why the ventricle is unable to relax? Because the pericardium is thickened. So once these AV valves open, the blood from the atria will gush into the ventricle, and thereby you will have the deep, accentuated Y wave. And accordingly, what will happen to your X wave? See, X wave is due to atrial relaxation in the JVP. Now, because atria are unable to send the blood into ventricle, right? Atria, they are unable to send the blood into ventricle. So, thereby what will happen to the atria? The atria, they are completely distended. Right, the atria, they are distended more than normal. The atria is relaxed or distended more than normal. That is what will happen in patients with the constrictive pericarditis. So, there is increased atrial distension because atria is unable to send the blood into the ventricle, and because of this increased atrial distension, what will happen to the X wave? Even the X wave in JVP, it is accentuated, right? Even X wave in JVP, it is accentuated. That is what is the pathogenesis. So, what is the problem here? The problem is the pericardium is thickened, and that is limiting the expansion of the heart. That is limiting the expansion of the heart. Next. Now, so basically the pathogenesis is diastolic dysfunction. See, we have many clinical conditions where you have diastolic dysfunction. You take restrictive cardiomyopathy, you take hypertrophic cardiomyopathy, constrictive pericarditis, pericardial effusion, cardiac tamponade. All these you have the diastolic dysfunction. Then followed by that, you need to know what is called as the square root sign. Square root sign is an indication of constrictive pericarditis, hypertrophic cardiomyopathy, restrictive cardiomyopathy, Takotsubo cardiomyopathy. So square root sign, it is seen in case of the constrictive pericarditis. Now, so this is what is your square root sign, right? So let me discuss in detail about this square root sign. Why does this particular square root sign appear in patients with the constrictive pericarditis? Okay. So, in case of constrictive pericarditis, let me tell you, the ventricular diastole is divided into three phases. Okay. So, ventricular diastole, it is divided into three phases. Okay. So, what are these three phases? Right, what are these three phases? Let me discuss. The early dip in diastolic pressure is due to isovolumetric relaxation of the ventricle, right? So you have the dip. What do you mean by the dip? Dip represent fall in the pressure of the ventricles. Right, fall in the pressure of the ventricles. So early dip in diastolic pressure is due to isovolumetric relaxation. Right, it is due to isovolumetric relaxation of the ventricle. Okay, so in the isovolumetric relaxation phase, definitely the pressure within the ventricle will reduce. And what about the second phase? See, after the isovolumetric relaxation phase, what will happen? The AV valves, they open. Right, the AV valves, they open. So once the AV valves, that is mitral and tricuspid valve, once they open, the blood from the atria will fill the ventricle. Right, the blood from the atria will enter into the ventricle with greater pressure. So there will be rapid filling. Right, there will be rapid filling of the ventricle. Right, there will be rapid filling of the ventricle following the opening of the AV valves. Right, and this phase of rapid filling is unrestrained in constrictive pericarditis. So there is more than normal increase in the diastolic pressure. After the rapid filling, that's all. The ventricle, it will have the limitation of the relaxation. Right, ventricle will have limitation of the relaxation. That is what will happen after the rapid filling. Further relaxation of the ventricle does not occur because of this thickened pericardium. Right? Because of this thickened pericardium, further relaxation of the ventricle does not occur. Okay? So, what will be the third phase now? Right? What will be this third phase? So, this third phase, it is also called as the plateau phase. In this phase, the rigid pericardium abruptly halts the rapid filling of the ventricle. So, in this phase, right, in this phase, the rigid pericardium abruptly halts halts the rapid filling of the ventricle when they reach the maximum cardiac volume. Okay, so during this phase, further filling does not occur, right? And this is attained near the end of first 1/3 of diastole. Okay, so when will this be attained? At the end of first 1/3, right? The end of first 1/3 of the diastole. So after this, right, after this, there is no further increase in ventricular diastolic pressure. No further increase in ventricular right, there is no further increase in ventricular diastolic pressure, and that is called as the plateau of that is nothing but the plateau. So when this ventricular diastolic pressure is plotted on a graph, you will get a square root sign. So dip is during isovolumetric right, dip is during isovolumetric relaxation phase, and this elevation is during early 1/3 of diastole. And this plateau is after that 1/3 of diastole, where further increase in ventricular diastolic pressure does not occur. That is what is the third phase or the plateau phase. And this is what is nothing but your square root sign in patients with the constrictive pericarditis. Now, let me discuss the clinical features of the constrictive pericarditis. So, clinical features, if you see, the question is, which of the following feature is not seen in constrictive pericarditis? Acute pulmonary edema, ascites, tapping apex, the pericardial knock. So, let me tell you that in constrictive pericarditis, due to constricting effect of the pericardium, the cardiac filling is impaired. Okay, so due to due to constricting effect of the pericardium, please remember the cardiac filling is impaired. Right, the cardiac filling is impaired. Okay, so thereby what will happen to the filling pressure? The filling pressure is increased, right? So what will happen to the venous pressure? Right, even the venous pressure is also increased, right? Because the both right atrial venous pressure, that is your IVC and SVC pressure, will be elevated, and at the same time the left side, that is pulmonary venous pressure, is also elevated. So the signs and symptoms of constrictive pericarditis results due to increase in the venous pressure. Okay. Right, signs and symptoms of constrictive pericarditis, it is due to increase in it is due to increase in the venous pressure. Okay, now let me discuss one by one, right? What will be the features due to increase in the venous pressure? So number one, you take on the right side. Please remember, right sided features or right heart features will be early then compared to that of the left heart features. Okay, the right heart features will be early then compared to that of the left heart features. And why? Because right ventricular myocardial thickness it will be less than left ventricular myocardial thickness. And that is the reason why the right side of the heart is affected first, then compared to that of the left side. Okay. So accordingly, what will be the manifestations? There will be jugular venous distension, right? There will be jugular venous distension, and you will have increase in the IVC pressure. And once there is increase in the IVC pressure, the venous pressure or the veins which are draining into the IVC, also their pressure also increases. Like for example, you take hepatic veins. In fact, the hepatic veins are the first veins which will face that increased right atrial pressure, right? They are the initial veins which will face that increased right atrial pressure through inferior vena cava. So accordingly, there will be hepatomegaly, right? Hepatomegaly, and because of this hepatomegaly, let me tell you, they will have ascites, right? So there will be basically cirrhosis of liver, right? We call this as the congestive hepatomegaly. Right, we call this as the congestive hepatomegaly, and because of this you have what is called the ascites precox. Now what is ascites precox? It is the scenario where you will have ascites first, then followed by that there will be development of the pedal edema. Right, you will have ascites first, then followed by the development of peripheral edema or the pedal edema, right? And the most consistent finding of constrictive pericarditis is insidious development of ascites of hepatomegaly. So usually you take, what do you mean by ascites first then followed by pedal edema? Usually you take any cardiac conditions. You will have congestive cardiac failure. You will have the pedal edema first, then followed by that there will be development of ascites. But in these individuals, there will be development of ascites first, then followed by that there will be development of the pedal edema, right? So these are the features of the elevated systemic venous pressure. Then followed by that you will have the features of reduced cardiac output. So if you see the features of reduced cardiac output, see in these individuals with the constrictive pericarditis, even the left ventricular filling, it is reduced. So when the left ventricular filling is reduced, obviously what will happen to the cardiac output? Even the cardiac output is also reduced. So once the cardiac output is reduced, what will be the clinical manifestations? That includes fatigue, because cardiac output is reduced and peripheral perfusion will be reduced. And next, the individual will suffer with hypotension. Why? Because cardiac output, once it is reduced, the blood pressure will be reduced. And then there will be reflex tachycardia. So these will be the manifestations due to reduced cardiac output. Now, then followed by that, we have a very important sign that is called as the broadband sign. What is this broadband sign? Broadband sign is the apical impulse. It is reduced and retracts in systole. Right? Apical impulse is reduced and retracts in systole. That is what is called as the broadband sign. And this will give an apical impulse as right, this will give the apical impulse as the tapping apex. That is what is called as the broadband sign. So if you see this question now, which of the following is not seen in constrictive pericarditis? Acute pulmonary edema, ascites, tapping apex, pericardial knock. Let me tell you, acute pulmonary edema is not the feature that you will see in patients with the constrictive pericarditis. See, acute pulmonary edema is secondary to acute left ventricular failure. Right, it is secondary to acute left ventricular failure. So this acute left ventricular failure resulting in acute pulmonary edema, it is the rare manifestation in patients with the constrictive pericarditis. You will not see that in patients with the constrictive pericarditis at all, because in these individuals the left ventricular failure, it is gradual in onset, it is not acute in onset. So the one which is not seen in constrictive pericarditis is the acute pulmonary edema. Now ascites will be there. I have discussed about the ascites precox. Tapping apex, that is called as broadband sign. And coming to the pericardial knock. So pericardial knock, it is an additional heart sound right, it is the additional heart sound that is heard in patients with the constrictive pericarditis. I will discuss about this additional heart sound in detail, okay. Next, before that, you see another question. A 45-year-old woman complains of increasing shortness of breath on exertion as well as orthopnea for previous 3 to 4 months. She has apparently recovered from pericarditis about a year earlier. On ECG, there is low voltage complexes, especially in the limb leads, and the chest X-ray shows the presence of the pericardial calcification. The presumptive diagnosis is constrictive pericarditis. Which of the following physical signs would be consistent with this? Increased jugular distension on inspiration, third heart sound, fourth heart sound, rolls at both lung bases, loud first and the second heart sound. So, you take in patients with the constrictive pericarditis, the heart sounds they won't be right, they are not loud, right, they are not loud. But if you take the JVP increases on inspiration, that is, there will be jugular distension on inspiration. And what is this particular sign called as? This particular sign, it is called as the Kussmaul sign. right? This particular sign is called the Kussmaul sign. Okay, so Kussmaul sign, it is the characteristic feature in patients with the constrictive pericarditis. And what is Kussmaul sign? That is increased jugular distension on inspiration is called Kussmaul sign. There are many other clinical conditions where you have the presence of the Kussmaul sign. Kussmaul sign is also seen in clinical conditions like restrictive cardiomyopathy, also present in patients with right heart failure, present in patients with constrictive pericarditis, present in patients with tricuspid regurgitation. So these are all the conditions where you have the presence of the Kussmaul sign. Okay, next. Now I just want to tell you one more important point, that is regarding the JVP in patients with constrictive pericarditis. So if you take JVP in patients with the constrictive pericarditis, JVP, it is elevated, right? JVP, it is elevated. And there are some abnormal waves in the JVP of constrictive pericarditis. And what will be that abnormal waves? That abnormal waves include accentuated X and Y descent, right? Accentuated X and Y descent. That is what you will have in JVP. That is what you will have in jugular venous pressure or jugular venous pulse. Now, in these individuals with the constrictive pericarditis, you will listen an additional sound. And what is that additional sound you will listen in patients with the constrictive pericarditis is the pericardial knock. Okay, so I'll discuss about that. But before that, you see a question as well. A 36-year-old woman presents to the rheumatology outpatient clinic with a 2 months history of stiff hands and wrist. She mentions that pain is particularly bad for the first few hours after waking up and is affecting her work as a dentist. On examination, the wrist, metacarpophalangeal joints and proximal interphalangeal joints are swollen and warm. What will be the cardiac examination finding in this patient? Ejection click, tumor plop, pericardial knock, loud S1, opening snap. So, now these patients, presenting with rheumatoid arthritis. And in patients with rheumatoid arthritis, the cardiac manifestation can be in the form of, right? Cardiac manifestation will be in the form of constrictive pericarditis. So in these patients with the constrictive pericarditis, you will listen an additional sound during diastole, and that is called as the pericardial knock. That is called as the pericardial knock. Now let me discuss few points about the pericardial knock. Why you have the presence of the pericardial knock? Pericardial knock, right? It is a diastolic sound. Right? It is a diastolic sound. And this pericardial knock, it is higher, it is having a higher pitch. Okay? The pitch of this pericardial knock, it is more than compared to that of your third heart sound. Okay? So it is a high pitched sound. Right? It is a high pitched sound. And it is heard or it is audible in the early part of diastole. And where will you see that? You will see that in patients with constrictive pericarditis. And why does you have, right? What is the pathophysiology behind the presence of this pericardial knock? See, this pericardial knock is produced due to sudden deceleration of ventricular filling, right? So this occurs due to sudden deceleration of right, this occurs due to sudden deceleration of the ventricular filling because of restrictive effect of the adherent pericardium. So in patients with constrictive pericarditis, there is ventricular filling. The ventricular filling will be there only up to 1/3, and after 1/3 the pericardium is not allowing right? The pericardium is not allowing the ventricle to relax the remaining. That means there will be no 2/3 and as well as there will be no the final part of your diastole, right? So the heart will have only up to 1/3 of diastole will be there. So after 1/3 there is sudden deceleration of further relaxation. Due to sudden deceleration of the further relaxation, these individuals, they will have the presence of, or you will hear the pericardial knock. Okay, right. So pericardial knock, it is a characteristic feature of the constrictive pericarditis. Now, if you take this added sounds, these are all added sounds that you will listen in cardiac disorders. You take ejection click. It is heard in patients with aortic stenosis and pulmonary stenosis. And it is a systolic sound, right? Ejection click, it is a systolic sound, right? And it is a high pitched sound. Then you take opening snap. Opening snap, it is a diastolic sound. You see all these three additional hard sounds: opening snap, pericardial knock, tumor plop. All these are right, all these are the diastolic sounds. They are heard in the diastole. And opening snap, you will listen that in mitral stenosis and tricuspid stenosis. Pericardial knock, you will listen that in patients with constrictive pericarditis. Tumor plop, you will listen that in patients with atrial myxoma. Right, you will listen that in atrial myxoma. So that is about the tumor plop. So these are all the added sounds. Okay, next. All are true in chronic constrictive pericarditis except Kussmaul signs is present. Ascites is not in proportion to edema. Commonest cause is idiopathic. Right ventricular and diastolic pressure is raised. So Kussmaul sign is present. Ascites, it is not in proportion to edema. In fact, it is more than edema. Okay, ascites, in fact, it is more than the edema. But commonest cause being idiopathic, it is an incorrect statement, right? Commonest cause we have discussed it to be tuberculosis, and right ventricular and diastolic pressure is raised. That is a true statement. Okay, so that is about the features of the constrictive pericarditis. But in fact, if you take the features of chronic, right, features of chronic constrictive pericarditis, let me tell you that there is decrease in ventricular and diastolic volume, right? Decrease in ventricular and diastolic volume. There is also decrease in stroke volume. So why there will be decrease in stroke volume? Once there is decrease in end diastolic volume, obviously there will be decrease in the cardiac output as well. So once there is decrease in cardiac output, the stroke volume. In fact, there is decrease in stroke volume due to which there is decrease in the cardiac output. Okay, and there is increase in EDP, right? There is increase in end diastolic pressures in both ventricles. Right, there is increase in end diastolic pressures in both the ventricles, right? And there is also increase in mean pressure in atria, right? Increase in mean pressure in the atria, and there is also increase in the pressure in the pulmonary veins, and there is also increase in the pressure in systemic veins. Okay, and then these individuals, they also have congestive hepatomegaly, next there will be development of ascites, and then Kussmaul sign is being present. Okay, so these are the features of chronic constrictive pericarditis. Okay, next, followed by that, so you see this question now, all are true in chronic constrictive pericarditis except is what? Commonest cause is idiopathic. It is an incorrect statement. Now, after having discussed about the features of constrictive pericarditis, let me discuss the investigations in patients with constrictive pericarditis. So, ECG, you have the presence of low voltage complexes. Right, you have the presence of low voltage complexes. See, what is the criteria for low voltage complexes? The amplitude of the QRS complex, it will be less than 5 mm in limb leads, and amplitude of the QRS will be less than 10 mm in chest leads. Right, amplitude of the QRS complex is less than 5 mm in the limb leads and less than 10 mm in the chest leads. And that is what is called the low voltage complexes. Okay. Now, what does the chest X-ray shows? Chest X-ray, it shows the presence of pericardial calcification and development of effusions. And echo or CT or MRI, this will show the presence of the pericardial thickening. Right, this will show the presence of pericardial thickening. Right, and CT scan of the chest is the best test to demonstrate the calcification of constrictive pericarditis. Okay, so CT scan, it is the best test to demonstrate the presence of calcification in constrictive pericarditis. Right, and cardiac catheterization will confirm the diagnosis. Right, will confirm the diagnosis. And let me show you the ECG of low voltage complexes. You see, this will be the ECG of patients with the constrictive pericarditis. So you can see that here. If you take the limb leads, right, so what is that you are observing in the limb leads? The amplitude of the QRS complex, right, it is less than 5 mm, whereas the amplitude of the QRS complex in the chest leads, that is less than 10 mm. Right, that is less than 10 mm. That is what you will see in constrictive pericarditis. And radiographic finding, what did I tell you? If you take the size of the heart, right, most of the times you will have the normal heart size. Right, you will have the normal heart size, right, and pericardial calcification, I said you will observe, but this pericardial calcification, let me tell you, it is best seen in or best seen on lateral view. Right, it is best seen on the lateral view, and it rarely involves the LV apex, and findings of calcification at the LV apex, it is more consistent with the LV aneurysm. So let me just show you the radiographic findings. Right, so this will be the radiographic findings, and you can observe that here. This will be your calcification. Right, so this will be the calcification. You can see that here. Okay, so this is the calcification that you will have in patients with the constrictive pericarditis. Next, so echocardiography, it demonstrates the thickened pericardium. But another important feature that you will see in echocardiography of patients with the constrictive pericarditis is you will see the presence of the septal bounce. Right, septal bounce. So a septal bounce reflecting the rapid early filling is common. So what is this septal bounce? Let me discuss. For example, you take during inspiration. During inspiration, there is increased filling on the right heart. Right, there is increased filling on the right side of the heart. Okay. So once there is increased filling on the right side of the heart during inspiration, the right ventricle already it is under very high pressure in constrictive pericarditis because right ventricle is unable to relax. So this right ventricle which is unable to relax, now it has to receive the blood during inspiration. Now when the venous return is increasing on the right atrium obviously it has to send the blood into the right ventricle. So what the right ventricle will do in order to accommodate that blood is that increased pressure in the right ventricle will push the septum. Right, will push the interventricular septum to the left side. So please remember there will be inspiratory reduction in mitral inflow Doppler. Okay, so there will be inspiratory reduction in mitral inspiratory reduction in mitral inflow Doppler pattern. And how much will be that inspiratory reduction in mitral inflow Doppler pattern? That will be more than 25%. Right, that will be more than 25%. Okay, so that means during inspiration, because of the push of the interventricular septum onto the left side, the blood from the left atrium to the left ventricle, it will be reduced. Right, the quantity of the blood which is moving from left atrium to the left ventricle will be reduced. That is what is called as inspiratory reduction in mitral inflow Doppler pattern of greater than 25%. Okay, next. So septal bounce and inspiratory reduction of left ventricular inflow, these two are characteristic features that you will see in patients with the constrictive pericarditis. Then, and the cardiac CT and as well as MRI, right? So this will show you the presence of the calcification, and you can also observe the pericardial thickening. And how much will be that pericardial thickening? That pericardial thickening will be more than 4 mm. Right? Pericardial thickening of more than 4 mm must be present to establish the diagnosis. Right? But no pericardial thickening is demonstrable in 20 to 25% of patients with constrictive pericarditis. Okay? And even certain MRIs, right? Some MRI techniques, they demonstrate the septal bounce. Right? They demonstrate the septal bounce and can provide further evidence for ventricular interaction. So that is about the cardiac CT and as well as the MRI. And the cardiac catheterization. Cardiac catheterization, this procedure is often confirmatory. Right? So if the question is asked, the confirmatory test in constrictive pericarditis, that will be cardiac catheterization, right? And let me tell you, in cardiac catheterization, you will be able to demonstrate the square root sign. Right? You will be able to demonstrate the square root sign. Okay. And please remember, what is the square root sign? The dip is during isovolumetric relaxation. That elevation is during rapid inflow, that is first rapid filling, and then plateau phase is due to further limitation of the ventricular filling. Okay, so that I have discussed in detail. Now, coming to the treatment. So you have the medical management and as well as the surgical treatment. So medical management, if you see, mainly you need to give diuretics. Why? Because there is ascites, pedal edema, and there is also pulmonary edema. So for which you need to give diuretics and you have to ensure that the fluid is completely drained out. And the next important thing is the salt restriction. And surgical treatment, if you see, pericardiectomy have to be done. Right, pericardiectomy should be done. Okay, and this pericardiectomy is done only if refractory to medical therapy. Right, so only refractory to medical therapy you need to do the pericardiectomy. Right, so that is about the treatment of the constrictive pericarditis. Okay, so therapy, and the other important thing is you also need to treat the underlying etiology. So treat the underlying etiology initially. Right, you also need to treat the underlying etiology initially. Right, and if there is laboratory evidence of ongoing inflammation, then anti-inflammatory medications may also have the role. Okay, so anti-inflammatory medication. Right, they also have a very important role in the treatment of constrictive pericarditis. And once the hemodynamics are evident, the mainstay of treatment will be diuresis. Okay, diuresis, it should be aggressive, and you know the diuretics, what we give is, we need to give we need to give the loop diuretics. Okay, loop diuretics like torsemide or bumetanide or furosemide should be given if the bowel edema is suspected. Right, so intravenous formulations, what we give is furosemide, but if you take the oral formulations, that includes bumetanide, right, bumetanide, and as well as the torsemide. Right, as well as the torsemide. Okay, and the other diuretics after the loop diuretics include thiazides and aldosterone antagonists. Right, thiazides and aldosterone antagonist. See, this thiazides and aldosterone antagonist, especially in the presence of ascites and liver congestion. Right, this aldosterone antagonist, what are the examples? That is spironolactone. And the other alternative medication is, right, the other alternative medication is eplerenone. So these are the aldosterone antagonists that you need to give in patients with a constrictive pericarditis. Okay, and surgical treatment, what did I discuss? That is surgical pericardiectomy. It should be recommended when diuresis are unable to control the symptoms. That means when the individual is refractory to medical management, that is the point when you need to do pericardiectomy. So this pericardiectomy removes only the pericardium between the phrenic nerve pathways. Right, whatever is there beneath the phrenic nerve pathways, that pericardium is removed. However, and most patients still require diuretics even after the procedure. Okay, so the part of pericardium, right, the part of the pericardium that is removed is the one which is present in between, right, the one which is present in between the phrenic nerves. Okay, but even after doing pericardiectomy, right, even after doing pericardiectomy, you need to give the diuretics. Right, and morbidity and mortality after the pericardiectomy are high and are greatest in those with most disability prior to the procedure. Okay, so morbidity and mortality right? It is high after the procedure, right? And it will be very much high in those individuals who have most severe disability prior to the procedure. So that is about the surgical pericardiectomy. And there are, right, and there are certain poor prognostic predictors. What are those poor prognostic predictors? That includes the history of history of prior radiation, presence of the renal dysfunction, and presence of higher pulmonary systolic pressure, right? Presence of higher pulmonary systolic pressure, and also in patients with abnormal left ventricular systolic function, right? And the individual also has poor prognostic predictors, or in those individuals with low serum sodium, even they have the poor prognosis. And in individuals with liver dysfunction, right, and also in individuals with older age, right, also in individuals with older age. So these patients, if they develop constrictive pericarditis, they have poor prognosis. And what about the pericardial calcium? Pericardial calcium, it has no impact on the survival of the individual. But if these factors are there in the individual, that definitely tells that the individual has poor prognosis. Then what about the good prognostic factors? See, prognosis, it is best with idiopathic cases, right? If in idiopathic conditions, they have good prognostic factor, right? And then infectious causes. And another important good prognostic factor is in scenario if it is secondary to bacterial or tuberculous infection, because you have the treatment for the bacteria and as well as tuberculosis, okay? And it is worst in post-radiation etiology, okay? So post-radiation etiology, here the prognosis is worst, right? Here the prognosis is worst, okay? So that is about the good prognostic factors and as well as the poor prognostic factors. So you see a clinical question. A 24-year-old man presents to the emergency department complaining of chest pain, and he reports having substernal chest pain of 2 days duration. The pain is worse with inspiration and alleviated by maintaining an upright posture. He also reports having fever recently. His medical history and physical examination are unremarkable, and ECG shows 2 mm elevation of the ST segment in precordial leads without reciprocal changes with concomitant PR segment depression. An echocardiogram is normal. What is the most likely diagnosis and most appropriate treatment approach for this patient? Acute pericarditis, you need to start NSAID. Acute pericarditis, you need to start prednisolone. Acute pericarditis, repeat echocardiogram in 1 week to confirm the diagnosis. ST segment elevation myocardial infarction, you need to start thrombolytic agents. So let me tell you, this particular clinical scenario, it is suggestive of, right, it is suggestive of acute pericarditis. Now, why is that you are telling it is suggestive of acute pericarditis? Because the individual has the history of chest pain, right? and this particular chest pain, it is increasing on inspiration, and it is alleviated by maintaining the upright posture. And ST segment elevation of 2 mm in all the leads except AVR, and PR segment depression in all the leads except AVR. These are all features suggestive of acute pericarditis. And in acute pericarditis, what is that you will give as a treatment? We will give NSAIDs as a treatment in patients with the acute pericarditis. Okay, and this will be the ECG in patients with acute pericarditis. So in acute pericarditis, you will have ST segment elevation in all the leads except AVR. In AVR, you have ST segment depression in patients with the acute pericarditis. Whereas in all other leads, right? Whereas in all other leads, you have the ST segment elevation. And this ST segment elevation is concave ST segment elevation, right? This ST segment elevation, what you have is concave ST segment elevation. Okay, that is what you will see in patients with the acute pericarditis. Okay, next. Then you see another important clinical scenario. A 23-year-old man reports a 3-day history of constant left-sided chest pain, which worsens with inspiration and activity. His symptoms were preceded by several days of fatigue, rhinorrhea and cough. Right? See, fatigue, rhinorrhea and cough. Rhinorrhea, so there is upper respiratory tract involvement, and then cough. Like, okay, cough is there. He is worried that he has broken a rib from coughing, and he reports no other symptoms and has no risk factors for cardiovascular disease. On examination, he is comfortable. Other findings on physical examination are as follows. Blood pressure 120/70. Right, heart rate like 94 beats per minute, respiratory rate 12 breaths per minute, temperature 100.2 degree Fahrenheit, lungs are clear, cardiovascular examination shows tachycardia, but otherwise results are normal. Which of the following should be appropriate step to take next in this patient's workup? Chest X-ray, complete blood picture, arterial blood gas analysis, electrocardiogram, none of the above. So the answer here, what you need to do is the electrocardiogram. Why? Because the clinical scenario which has been given to you is the acute pericarditis. And for acute pericarditis, the investigation that will be helpful will be the ECG among the options which have been given to you. And what will be the ECG findings in acute pericarditis? I have just discussed previously. Now, how are you able to tell that the individual is suffering with acute pericarditis? Number one, the individual has rhinorrhea and as well as cough. That means an upper respiratory tract infection. Most commonly, the upper respiratory tract infection are secondary to some viral infections. And followed by that, is having left-sided chest pain, and this left-sided chest pain, it is increasing on inspiration. Then why don't you consider it to be a pleuritis? Why? Because the lungs are clear, so I cannot consider the pleuritis, because in pleuritis you will have the presence of the pleural rub, right, which is not there in this particular patient, right, which is not there in this patient. So that makes me to think of the acute pericarditis as the next important etiology causing this particular clinical scenario. Okay, and the other thing is the cardiovascular examination is also showing you the presence of the tachycardia, right? So this is about. Now, why am I discussing the clinical manifestations of acute pericarditis in the topic of constrictive pericarditis? Because let me tell you, recurrent acute pericarditis can make the individual to progress to the development of constrictive pericarditis. Okay, next. Now, yes, so these are the four things which you should be able to differentiate, these four clinical scenarios. That is cardiac tamponade, constrictive pericarditis, restrictive cardiomyopathy, and then right ventricular myocardial infarction. So these four clinical conditions you should be able to differentiate one from the other. So all these, they are characterized by diastolic dysfunction. So you take the presence of the cardiac tamponade. In cardiac tamponade, or you take this clinical sign, that is pulsus paradoxus. It is present in cardiac tamponade, usually absent in all others. Occasionally, rarely you can have the pulsus paradoxus even in patients with the constrictive pericarditis as well. And if you take the JVP finding, in cardiac tamponade, Y wave is absent and X descent is present, right? And in case of constrictive pericarditis, both of them, they are prominent. Whereas in restrictive cardiomyopathy, prominent Y wave is rare, it may be present, and prominent X descent is present. And in right ventricular MI, both of them are rare. Next, presence of the Kussmaul sign. Kussmaul sign is not present in cardiac tamponade, whereas it is present in the remaining three conditions. And what about the third heart sound? Third heart sound, it is present in right ventricular MI, but not in any other condition. So you have what is called RVS3. And what about the pericardial knock? Pericardial knock, it is often present in patients with the constrictive pericarditis, but absent in other conditions. Right? Absent in other conditions. So clinically, this is how you need to differentiate cardiac tamponade, constrictive pericarditis, restrictive cardiomyopathy, and then right ventricular MI. So why am I telling you the differential diagnosis of these conditions is because in all these conditions you have the presence of the diastolic dysfunction. And how will you differentiate this based on the ECG? So where is that you will have low voltage complexes except in RVMI, in all other conditions you have low voltage complexes. And where is that you have the presence of electrical alternance? Electrical alternance, it is present in patients with the cardiac tamponade, you have the presence of electrical alternance. Then coming to the echocardiography. So where is that you have the presence of thickened pericardium? Thickened pericardium is present in patients with constrictive pericarditis but not in any other condition. And what about pericardial calcification? Even pericardial calcification is also present in constrictive pericarditis but not in any other clinical condition. Then what about the effusion, the presence of the fluid in the pericardial space? You will have that in patients with a cardiac tamponade but not in any other clinical condition causing diastolic dysfunction. Then coming to the RV size. Right ventricular size in cardiac tamponade and constrictive pericarditis. In both of them, they are small. Right? Cardiac tamponade, constrictive pericarditis. In both of them, the RV size will be small. But in restrictive cardiomyopathy, more or less, the RV size will be normal. And in RVMI, right, in case of the right ventricular MI, the RV size is enlarged. Right, RV size is enlarged. Then what about the myocardial thickness? Myocardial thickness, it is increased in patients with the right ventricular, restrictive cardiomyopathy. See, pericardial thickness is increased in constrictive pericarditis. Myocardial thickness is increased in case of restrictive cardiomyopathy. Right? And where is that you will have the right ventricular diastolic collapse. RVDC means right ventricular diastolic collapse. Right ventricular diastolic collapse, it is present in patients with the cardiac tamponade. Then where is that you have increased early filling? Increased early filling, you will have that in patients with the constrictive pericarditis and as well as restrictive cardiomyopathy. And where is that you will have exaggerated respiratory variation in the flow velocity? Respiratory variation in the flow velocity, you will see that in cardiac tamponade and as well as constrictive pericarditis. And where is that in CT scan you will have the presence of thickened or calcified pericardium? You will have that in patients with the constrictive pericarditis but not in any other condition. Then where is that you will have equalization of the diastolic pressures? Equalization of the diastolic pressures, they are usually present in the first two clinical scenarios, that is in cardiac tamponade and as well as constrictive pericarditis. You will have the equalization of the diastolic pressures. Okay, so these are some of the very important differences between all these clinical scenarios, right? So with this, I am done with the topic of constrictive pericarditis. Thank you very much.